Good.
Yeah. All the best.
Yeah. Good evening, everyone. In behalf of Mindray Medical India, I welcome you all to this auspicious evening for another exciting learning session. We extend our thanks to Dr. Harshad Ruprela and the entire Chhattisgarh Radiology Academy team and faculties Dr. Ashok Khurana and Dr. Chander Lulla for another collaboration for this exciting webinar. Without further ado, I'd like to proceed with the Mindray Technologies session with a small video focusing on our AI-based technology on pelvic floor imaging. From here, I'll give the session to Dr. Harshad, sir. You can introduce the speaker, sir. Thank you, sir.
Yeah, thanks, Bishuru, for that wonderful video. I think you have given the video of pelvic floor imaging only.
Yes, sir. Yes, sir.
Many of the images were very new to us because most of, I don't know, but at least most of us are not practicing, pelvic floor imaging.
Yeah.
And that's the reason I have kept this topic, which is very useful for both the radiologist and the gynecologist, as it's a very new topic, and we need definitely high-end machines for the same. We need a volume probe. That's what I can see.
Yes.
And many of us also are very, very poor with 3D handling of pelvic floor, basically.
Yes.
So I think today's session is going to be new for most of us. And it might be a little bit of stress. It might give stress to our brains, because since anything new we have to concentrate more. So I request the viewers to kindly pay attention and give maximum, get maximum from this talk. And Khurana sir, I don't know if he's coming or not. I am not able to see him online yet. I think it's 8:05. I think he's going to join by 8:10.
Yeah. It's a little early, sir. Yeah.
Yeah.
I think
You had a talk this evening, no?
Yeah. So Khurana sir is going to join by, I think, another 5 to 10 minutes. We have to wait.
Sir is here only. I can see his name now, Dr. Harshad. He's here.
Okay. Okay,
Yeah.
okay.
Good
Nice.
evening, Dr. Khurana.
Khurana
Hi,
sir, good
sir.
evening.
Hi.
And
Good
Hi
evening.
everyone. How is everyone?
Good evening.
Everyone, so thank
Hey.
you.
very nice to see you, sir.
A pleasure indeed, my dear. Pleasure indeed. Sorry, I'm not dressed for the occasion.
I don't know, sir, how many talks you have given in this since pandemic, the webinars. I think it's uncountable.
I stopped counting. I completely stopped counting it, and sometimes it just coincides with the end of the clinic.
Yeah, Harsad, what you're telling, na? You have to learn from Dr. Khurana, sir.
That's
So what
so sweet of you. Thanks, Sudhir. That's so kind of you.
we have to learn a lot of things, Sudhir sir, from Khurana sir.
Yeah.
There are many things. The amount of energy and the freshness in the
Yeah.
face can be still seen in sir's. After working, all day long, still he looks so fresh as if he have just taken a bath.
That's my secret.
And he participates in banquet also. Dances very well.
Oh my God, sir. Ultimate, sir. Sir, we are going to begin the talk.
Yes.
So before beginning the talk, I would like to introduce. Actually, I don't have to introduce Khurana, sir. Everybody knows him. I think now the pan India, all the radiologists and gynecologists at least are knowing him. And I don't have to introduce him. What he has been, he's the immediate past president of Society of Fetal Medicine. And one thing I would like to mention here, which is very important, is that he has been a very, very, very great initiator to for us, for all the youngsters. He has pushed us to the to come to the academic platform and try to increase the academic activities in respective states. So that's the under him. Actually, I have got so many times I have spoken to Khurana sir, and because of his encouragement, we also feel that we should keep doing at least once in a month, if not every month, or if not every week, at least once in a month, we should do such activities and try to bring out topics which are very useful and for our day-to-day practice. So that's the reason I have kept very complex topics for this session, and we need a expert also to explain this very complex topics to all of us. So today's topic will be pelvic floor imaging and pelvic Doppler imaging by Dr. Ashok Khurana, sir. I give the platform to him. Sir, please begin. We're all waiting for you.
Oh, we start off already? I thought we're starting 8:15.
I think, sir, you need an extra time, sir, because it's
No,
a very complex topic.
Now we're going to do these two. Which one do you want me to do first? You want me to do mine first and second, and then Chander is doing third, right?
Yes, sir, exactly.
Yeah. Give me 2 minutes to get organized. I'm just going to open my talk, huh?
Sure, sir.
Yeah.
Sure.
Just one moment. I will get organized on this, and just bear with me for a minute, huh? See off the video. एसी ऑफ कर दीजिएगा। Okay, we're all set to go. Harshad, can I start now? Or are we?
Yes, sir. Please start, sir.
Yeah, wonderful. So I'll start with my screen share. I'm not able to share my screen. Can we start with the screen share?
Bishwarup, please, can you just take care of this?
Yes, sir, you can do it now.
Wonderful. Thank you. Okay, so are we all set? Are you able to see my screen now?
Yes, perfect, sir.
Yes, sir.
Perfect. Yes.
Yes, and you're getting my voice right and my pointer is well seen, yes?
Yes, sir.
Okay, so just bear with me. I will just make sure that I start with the correct slide. So are you able to see my slide again now neatly?
Yes, sir. Please go on.
Perfect. So thanks so much for this wonderful invitation. I think of Chhattisgarh as a second home because of how close I've grown to it all over again. I used to be part of Chhattisgarh when it was still Madhya Pradesh, and this time it's a pleasure indeed to go over and to my original wonderful Indian Radiology Organization, Indian Radiology and Imaging Association. And thanks so much for this invitation. I'd like to thank all the office bearers of the Chhattisgarh IRI, as well as Harshad in particular, for pushing me into this. It's actually been a lot of fun, and I thought I will choose these two topics so that we can convey to the people today, both at the younger and at the medium level, that there's a lot more in imaging in female health, women's health, than we could ever imagine. And that it is extremely important to do this because it gives the answers to very important clinical questions. And one of the problems that we must acknowledge to ourselves is the need for pelvic floor imaging. So that is going to be my first talk. And the second talk, as you all know, is going to be on the role of Doppler in gynecology imaging. So I'm going to take you through how to get videos like this, how to interpret videos like this, how to get similar images in disease processes, and then how to go about actually doing a good job of pelvic floor imaging. Now, I must mention to you that we'll divide it into 2 or 3 parts. A clinical perspective, simply because we need to have that, and it's not really a part of most of the textbooks of radiology and imaging, unfortunately. I will then talk about imaging techniques, and that is extremely important because if you don't get the right planes and the right technology, you're not going to be able to actually figure out how to best help the patient and the clinician. And last but not the least, and very importantly, a pattern recognition so that that image sits in your mind and you know exactly how to handle this. And in some places, I will tell you where we do need to do a quantitative analysis, although the world is now moving more and more to using just a qualitative analysis when it comes to pelvic floor imaging. The technology is extremely important. We do understand that in pelvic floor imaging, we have so much information in the coronal plane, as you see in this image here where I'm moving my arrow, that we cannot do without 3D. And a lot of people say, but sir, how do we manage 3D? 3D is expensive. Well, we must admit to ourselves, that 3D comes in low-end 3D machines, medium-end 3D machines, and high-end 3D machines. And that even on low-end 3D machines, you can do all of this work very, very easily. So please don't think of cost, think of the benefit that we're going to be able to give our patients, because this business of pelvic floor imaging is something where we truly have to handle a large number of clinical conditions. And the most frequent of these is urinary incontinence. The second one is fecal incontinence and flatus incontinence. And also we have pelvic organ prolapse. Now, apart from this, what also comes under pelvic floor dysfunction and needs to be assessed is whenever we have recurrent urinary tract infections in the female, a persistent dysuria urgency or frequency, and also in sexual dysfunction and orgasmatic dysfunction. So there is this large area that we need to explore. And the reason why we need to explore it is, let me give you a simple example. The incidence of urinary incontinence, for instance, almost every woman by the age of 50 has had at least one episode of urinary incontinence. And beyond the age of 60, 1 in every 10 women will have stress urinary incontinence. And it is your duty and mine to help out to handle this, because if she smells of urine all the time, and that's what happens when you have urinary incontinence, then she's going to be a social outcast. And she's going to be a social outcast because of her own approach and also the approach of society towards anybody who has a problem. And therefore, you need to do that. For the rest of the things, it's actually supporting the gynecologist in taking decisions, and we will discuss this as we actually go along. The clinical spectrum, as you've seen, is very wide. And as I've mentioned, we've had very high morbidity and quality of life issues, and we need to do something for the women. But the important thing is that there are answers. We have established and evolving treatment options, but the choice of these options depends on the demonstration of anatomic abnormalities, because some of these are surgical options, and some of the surgical options don't always have good results. So we're going to have to add that element, and therefore you do need this background of knowing that there is a clinical background to this whole thing. The other thing you need to know is that there are a lot of surgical procedures which are becoming more and more common, which we had no idea of when we were growing up, and we had even no idea in recent times when you went to medical college, for instance, and that is the fact that we have minimal access surgery as well as highly sophisticated technology surgery, which you must be knowing. We heard about a prolapse repair with gynae mesh, for instance. We have a sacrospinous ligament fixation laparoscopically, which is done now. We have a Manchester or Fothergill amputation, as well as suspension of the pelvic floor after surgery. But that is now laparoscopic surgery, and we can add a laparoscopic sling to that. You can have defects in the posterior compartment, which only get repaired, in an isolated manner whenever you have rectal symptoms. And then, of course, for urinary incontinence, we have transobturated transvaginal tapes. And you also might need the repairs of cystoseals and enteroseals and so on, and a perineoplasty. So all these are procedures that have fallen sometimes under disrepute and then come running back. But the more we use ultrasound to guide the surgeon, the better the results are. And the better the results, the more the uptake. The more the uptake, the better the quality of women. And isn't that what you and me are truly looking for? So we must become more and more aware. And for this, I would suggest that each one of us should attend at least some urogynecology clinical seminar sometimes and see what they're talking about, so that we can all be on the same wavelength. It's a good idea to be part of these teaching sessions and try and learn what they actually discuss. Then there's this question of imaging in urogynecology. Why ultrasound? Not just because it can be done, because it is now proven to be reliable, and it's been now proven to be reliable for over 2 decades, and possibly superior to other methods, which is a clinical evaluation of the pelvic floor and an MRI evaluation of the pelvic floor. Also because it answers some very serious questions. And let me give you some examples here. For instance, one example here is that when we are looking at a diagnosis of a urethral hypermobility, which means on the ultrasound I've demonstrated that the urethra moves too far down and pulls the bladder with it, then this is far better handled with a transobturator midurethral sling vis-a-vis an intrinsic sphincter deficiency handled with injectable bioagent. So if I'm able to demonstrate the difference between the patient's symptoms being due to a urethral hypermobility compared to an intrinsic sphincter deficiency, then the treatment changes completely. Also, if I presume that the patient had a sphincter deficiency and I handled just the whole problem with an injectable bioagent, she would still have the problem and then would say, okay, these treatments are no good. So you have to help the clinician handle this situation intelligently. And there's another very important thing, that when these meshes and tapes are used, there's a lot of dyspareunia, which can then destroy the quality of life and the relationship between the male and female partner. So in that situation, it's very important to realize that we should not be doing any harm. And the demonstration of the lesion by imaging then becomes important to make sure that the patient can make the right choices. Now, the most important thing is that a few years ago, because of the high failure rates of procedures and the complications of surgery in the United States of America, the FDA there decided that everything should be put to an end as far as surgical approach to urogynecology is concerned. It was very short-sighted. And of course, this was way back in 2011. And they mentioned that complications associated with transvaginal placement of surgical mesh for pelvic organ prolapse needed to be updated. But there were two areas where things went wrong. One, that the lawyers got onto it and they destroyed the peace of the medical profession, and understandably so, because that is their profession. But it was important for us to point out as a profession that the update that the FDA gave related only to this particular condition and not to the other conditions. The good news there is that way back even in 2011, and that, as you notice, was dated July 23, the American Association of Gynecological Laparoscopists said that, look, there is this report, but the report specifically pertains to a transvaginal placement of mesh for prolapse repairs, and that the conclusions and the recommendations do not apply to the use of mesh for treatment of stress urinary incontinence or the use of abdominally placed mesh, whether you do it by an open method, a laparoscopic method, or a robotic sacrocolpopexy. It was very, very important then to tell the public as well as the other doctors that we were on the wrong track. So when you handle things like that, and a professional organization handle things like that, we come back into perspective and realize that yes, things will change and we're on the right track. Then, of course, when that got sorted out, and that got sorted out within 4 months of that announcement, we realized that we were answering so many of the patient's questions. Whenever the patient has a problem, the patient wants 4 answers. They want to know what's happened to me. They want to know why this is happening. They want to know what it implies to their future existence and what can be done about it. And the information that you get in pelvic floor ultrasound dysfunction is something that will answer all these 4 questions. And without these 4 questions, you don't get the answers, because without pelvic floor imaging, you cannot answer why it's happening, and you cannot answer the implications for the future, and you cannot say what can be done about it. Therefore, you need to give these answers very, very importantly. Do remember also that we need to work on this together. Gynecologists are new to this, pelvic surgeons are new to this, laparoscopic surgeons are new to this. The field itself is really changing a lot, and therefore we need to work together. Because a lot of the times there's pelvic floor exercises and a good protein diet which might help a lot, or lifestyle modifications such as less coffee at night or fluid restriction at night, so that you don't have so much trouble at night. There was this wonderful antipsychotic drug called duloxetine that worked very well for this condition. Unfortunately, duloxetine got associated with hepatic complications, and we don't have it available anymore, and therefore we're left with other things. Also, do remember that the postmenopausal atrophy can cause a lot of problems with the pelvic floor, because there is an atrophy of the muscles there, and that might then get corrected just by a local or replacement hormone therapy. And surgery then is the last option. And this is the perspective we need to have, because we need to guide treatment on these lines, and we can guide, as I will show you when I show you the pattern recognition slides. Now, the conventional protocol when a patient used to present with a problem was that we used to do a detailed perineal or a PV examination when a gynecologist was approaching this problem, followed by a general physical examination, followed by urinalysis and appropriate blood work for her general health and to exclude a urinary infection. And then there were these absolutely mind-blowing names. There was B-chain cystourethropography, very difficult to pronounce, something we don't do anymore. There was uroflowmetry, very difficult for the female, which we do use sometimes occasionally. There's urethral pressure profilometry, which is actually very useful even today, but that's no longer a part of a preliminary protocol that's done much later in the protocol. There's MRI and dynamic MRI, and we will discuss this in detail. The problem here is that dynamic MRI is cumbersome. Dynamic MRI is not reproducible. Dynamic MRI is much more expensive than ultrasound, and it's not generally available in most parts of the world. So if it's not available in most parts of the world, then we do understand that, yes, we have to be careful and try and do a test that is much simpler, and that is 3D ultrasound, which is a dynamic 3D ultrasound scan. Remember also that the number of situations requiring a cystoscopy by a urologist have also reduced, and that we truly do not have to be hassled about it at all, and that we can make sure that the incidence of cystoscopies goes down tremendously, which is very nice, because cystoscopies themselves can introduce infection in the postmenopausal female who has reduced local immunity. Now, what we have now with us is conventional radiology. We do use that. Video cystourethropy, which we're using less and less, which is a radiological technique of voiding and actually seeing when the patient voids. And we have ultrasound and we have MRI. And let's just discuss the role of conventional radiology first, and then go on to the rest of it. Remember also that when we talk about ultrasound, we don't talk about primitive machines like these images where you could barely make out where the bladder began and where the pelvic floor began. But truly speaking, images like this, where with the help of a high frequency transducer, you can see the entire urethra, you can see the urinary bladder, and here you can actually make out what we talk about all the time: the symphysis pubis, the anterior extent of the bladder base, the urethra, the entire course of the urethra, the dome of the urinary bladder, the vagina sitting behind the urethra, and the anorectum sitting at the back. And we will discuss this in detail. Now, the newer protocol is that once you've done a clinical examination and some general tests for patients' good health, we do a KUB and a pelvic ultrasound scan of the usual type, which would include a transvaginal examination, because we'd like to exclude other pelvic pathology, such as a very, very large uterus or a massive adenomyosis or a urethral pathology or a large fibroid. We always like to check for post-void residue, because that gives tremendous information on what happens in a dynamic situation. And then we go on to introital and translabial ultrasound directly after you've done the KUB and pelvic ultrasound, and do 2D studies, 3D or 4D studies. And we also, to a certain extent, use power Doppler when we want to see whether there's any vascular atrophy associated with muscular atrophy. And we will discuss this bit. The appearance, like I said, was exactly as you see here, that this is the urethra and the rest of the bladder, and this is the same image I showed earlier. Now, the one thing that we like to look for is the opening of the urethra, and that's called funneling. And funneling can be present at rest, like you see in this patient, or it can be present intermittently, just at random. It can be present in patients who have genuine stress incontinence, which means every time they cough, the funnel opens, and when they stop coughing, the funneling stops, or they make a loud expression like, "Oh my God," and then they have urinary incontinence. So that is something that you have to correlate on the ultrasound in real time and make sure what's going on. And flat images like this showing a funnel have no value. Funneling has to be demonstrated in a dynamic way when you're actually doing a translabial or an introital ultrasound scan, and we got to figure out that at the same time. Remember that applying Valsalva strain is a very important part of the technique. And to make sure that the patient applies Valsalva strain, we use the same image, the symphysis pubis, the urethra, the urinary bladder, and the patient has to be taught Valsalva. The patient has never heard of the word Valsalva, and then you have to teach them that, yes, you have to blow your cheeks up, you have to apply pressure below, you have to blow your tummy outwards, you have to hold your breath, and then apply pressure below and keep on applying. And then when you teach the patient a few times, then they're able to do it well. So you keep observing, and then you can demonstrate what a beautiful sister seal this patient actually has. If you don't do it, you'll never be able to see how low this bladder is actually moved during Valsalva, and then that is not such a good idea. Now, I must also tell you that the words introital, perineal, and vaginal ultrasound are used in an intermixed manner. Introital and perineal actually just refers to placing the transducer at over the labia. And so some people call it translabial, some people call it introital, some people call it perineal. But the vaginal ultrasound is what follows. And here again, there lies a huge difference. Because when all this started off many years ago, it started off in Australia, and the gentleman who did it, Hans-Peter Dietz, used a transabdominal 3D 4D transducer to get images. The problem there has been that although he remains the most vociferous and the most highly quoted researcher, the degree of anatomical delineation is far better when you use a transvaginal transducer placed on the perineum. And therefore, to get an image like I was describing with the symphysis pubis here, the urethra sitting over here, the vagina here, and the anorectal angle here, you truly need a higher frequency, at least 5 and preferably a closer to 9 megahertz or even a 12 megahertz transducer. Remember that looking at the bladder wall and looking at post-void residue is as important a part of the study, and you must include this as part of your KUB and pelvic ultrasound scan, and you must include the introital ultrasound as well. Now, the things that we often pick up are increased post-micturition residue, which is not related to incontinence, tuberculated urinary bladder, which may be related to either a neurogenic situation or a urethral stenosis. You might pick up bladder or urethral diverticuli, bladder calculi, or foreign bodies or displaced IUCD. And therefore, when you're assessing for pelvic floor, you don't confine only to the pelvic floor. You do a complete evaluation because it's got to be done in that situation itself. The other thing, like I mentioned, was, of course, a periurethral mass or an intravesical mass. Anterior uterine fibroids. And then, of course, when you demonstrate a discordant funneling of the proximal urethra when the patient is not voiding. Now, the information that is required is the documentation of incontinence, which means is it genuine stress incontinence or is it just an urge incontinence? And the estimation of associated causes. And so let's see how we go about this. The first thing to do is to understand the orientation. The orientation is that the vaginal transducer, which is what I use all the time, has an orientation along the long axis of the patient. The other thing is that the beam should be wide enough to include the symphysis pubis in front, to see the base of the urinary bladder and the urethra in the middle, to look at the entire vagina behind that. And unlike what we used to do in this diagram when we made it a few years ago, we now extend the plan to make sure that we include the anorectal angle as well. So what we do now is something like this, which is symphysis pubis, urethra, vagina, and the rectum and the anus with an angle like this. This is extremely important. And then you put on your 3D and you study this particular area. Now, the reason why we now use more and more ultrasound and less MRI is also because when we look at the muscle mass entirely, it's not so well defined on MRI. And even when MRI machines have improved, to get an image like this takes you almost 25 minutes of reconstruction. Whereas to get an image like this on ultrasound takes you no more than 1 or 2, it takes you no more than less than a minute, maybe 2 minutes if you have to do a bit of adjustment and the patient is not very comfortable. So therefore, we have to be sensible when we approach this. We don't need to pick up the individual muscles here. So if I say that, look, this is the pubovaginalis and this is the puborectalis, and then we have a pubococcygeus, etc. That's not what we need to do. We need to identify that the muscles begin here, that this is the entire Levator Ani complex, that we see the urethra in the center on 3D, that we see the vagina right behind it, and you see the anal canal right at the back, and you can see the last portion of the Levator Ani, which is the pubococcygeus complex, as well as the pariformis sitting right next to it. Remember that the anococcygeal raphe cannot be picked up either on on MRI or an ultrasound so far, and we do hope in the future we'll have that resolution as well. But you can see here why we use ultrasound, because the contrastiness of 3D is far more than the contrastiness of MRI. This is the image you get when you do a 3 megahertz transducer, which is your standard transabdominal transducer based on the perineum. The line of view again is this, and therefore you will get the same thing. But notice how you can barely see the vagina clearly. You cannot see the musculature of the anal sphincter clearly. You can, of course, see the levator ani, but we're really looking at details of the rest of the system as well. And notice how you can barely make out the urethra. And therefore, I always use a transvaginal transducer. Now, some people like to use a big window so that we don't miss out on anything. And some people say, oh no, it should be a narrow window here. Doesn't matter which one you use. The important thing is two things. One, that we must make sure that the inner rectum is included. And that sometimes when we do this, you might not be able to pick up the portion at the back behind the rectum because that has gone into shadow. So before you say that this is a disruption of the muscles, make sure that you make an angle that includes the back. So it may not be a box just like this. You'll have to tilt that, and to tilt that, you can actually move the original image. And you have to get and see whether the muscles are truly seen and that the anal canal also is truly seen. So a real-time orientation is sometimes necessary to make sure you're in the right plane. Now, in terms of 4D, again, you can do a real-time evaluation. And here again, you can see the urethra here, the vagina here, which is usually H-shaped, but it could be in different shapes, and the anal canal at the back. And here is the actual Levator Ani complex. When we do it in 3D, the resolution is far superior. We know that this is the advantage of 3D. And then you can actually make out the nice, clear anatomy of the anal canal very well, and the inner rectum, as they like to call it. You can make out the vagina a lot better, and you can make out the urethra a lot better. You can also make out that the muscles at the back seem to be complete, but there is a disruption here. Well, I can't call it a disruption because I don't see the whole thing. So here, this would obviously be an atrophy rather than anything else. And the atrophy could be just age, it could be less protein, and also it could be a lack of hormones many, many years after menopause. So that would then be the differential diagnosis. But do realize that a 3D image has more resolution than a 4D image. Now, you can go further and understand that the pelvic floor really is not a single plane. It has thickness, and the thickness can be as much as a centimeter or so. And therefore, it might be wiser to have a topo on your 3D and move all the way from where the transducer is to all the way up into the rectum, so that then you can get all the images that you were truly looking for. So here I see more of anal canal, and as I come up, I see more of rectum, and that is how you work on it. And remember again that the vagina can be seen in different shapes. You could have a very patulous vagina, which is not related to either childbirth or to nulliparity or to virginity. You can just have different shaped vaginas, and some of them can be V-shaped, and some of them can be H-shaped, and some of them can be box-shaped, and this is a normal variation. But to realize that you can use that method. When we draw these lines across, it's sometimes useful to shift over from a standard rendering to a line drawn along what we refer to as omni-view rendering. We can choose a line, and the top of the line is shown by a head. And then when you freeze that line, the line can be drawn at the back, and you can move that line without fixing the other end of the line to make sure that you get the back portion. I use this technique of omni-view a lot to be able to identify the posterior complex very, very well. When it comes to anatomy, the urethra and the vagina are referred to as the anterior part of the perineum, and the inner rectum and surrounding areas are referred to as the posterior compartment. And so, like I said, you can do a nice line drawn exactly the way you want to be able to make sure that you see everything in detail. Remember that here again, when we do compound imaging, which is a 3D technique by pressing a button and summating the slices, you can actually get a much better detail between gray and white and black. And so a not so well-defined vagina can be better seen with VCI, and therefore you are much more comfortable just pressing that button. The way we go through this by moving that line up and down can also be automated by choosing a start plane and by choosing an end plane. And that shows you the entire thing. In case you don't have a multi-slice available, you can use this translation cine. And you can see how we start the rectum here, the vagina seen here, and the urethra seen here. And there truly isn't anything more to this than seeing these and then seeing the Levator Ani complex. I'm repeating this so that today it works like a workshop, and you carry this message home and try tomorrow morning, and you'll be getting these images as comfortably as I do. Remember that apart from that translation cine I showed you, you can see everything in real time. So you can use the 4D button and make sure, and you can either have fancy colors if you like fancy colors, or you can do everything in gray. Patients tend to believe that anything in 3D is supposed to be colored, so you can go by that. But I like to believe that you need the information. Doesn't matter how your eye picks it up. Some people pick it better in sepia, and some people pick it up much better in black and white. Now, it's also important to realize that the one measurement that might be useful is to actually measure the space between the extent of the Levator Ani, and you do it at rest, and you do it after a first Valsalva, then you teach your patient, and then you go ahead and you do an optimal Valsalva. And the ballooning can be seen then, and that would indicate that yes, there is a deficiency in the ballooning of the Levator Ani, or I mean, it just doesn't hold. And the area will tell you whether the ballooning is mild, moderate, marked, or severe, and that depends on how you measure that. How do you measure? It's a standard formula. You measure this dimension, you get the area, or you can trace around, and the circumference is then translated by the machine into an area. Now, the variants that we were talking about is this, the usual H-shaped vagina and the V-shaped vagina, all of which are completely normal variations. The important thing is that how do we carry this whole thing out, and how do we assess for funneling? Like I said, we use at least a 5 megahertz, preferably a transvaginal transducer. You warm the gel, because if you don't warm the gel, the labia can become puckered from the cold, and then the sound doesn't travel. When we try incontinence, or when we get the patient to urinate, it's very difficult in the supine position and very cumbersome in a standing position. So I normally have these patients in a semi-reclining position. We raise the head end up off the bed by about 25 to 30 degrees. And then you make the patient support herself on the elbow, and then it's very easy for her to do Valsalva. And when you want to actually watch urination, you can do that as well with the patient in a semi-reclining position. Remember, of course, that the long axis of the transvaginal transducer must be along the long axis of the patient's body for a correct orientation. Now, after you have finished your orientation, you can angulate it upwards or downwards or right or left, because sometimes the long axis of the vagina and the urethra and the bladder don't always coincide with the mid-sag section of the patient. It might be all a bit to the left or a bit to the right, and therefore you have to move your transducer to get an optimal position. Then you go ahead and assess the urethra, the bladder, the periurethral tissues, and exclude any abscess or mass over there. You look at the endopelvic fascia, which you look at in 3D, and then you assess the vagina and the rectum in the same image like I've been showing you on so many images, yes. Then you go on to see funneling, whether it's present at rest. You then also make the patient strain and see for funneling. You also see whether when the patient does the Valsalva, the urethra is fixed or hypermobile. Hypermobile is one that moves way down below the symphysis pubis. You assess subjectively the bladder neck descent. And then you try and go on and ask the patient to repeat everything when she is rested, when she's relaxed with her muscles, and then you ask her to clench as if she's trying to prevent the passing of urine and stool. You first ask her to try and clench so that she's not passing any urine. Then you ask her to extend the clenching, go more backwards to try and prevent stool passing. Tell her it's like when you're in a toilet and there's a long line and you want to hold back. And then you watch the entire pelvic muscles move in 2D and 3D with rest and with contraction. And then, of course, the anatomy of the pelvic floor using a 2D first and then a 3D after that. Now, this business of watching is like this. So you have, like I said, contraction, and then you watch. There's a change. You watch with Valsalva. Here, there is no hypermobile urethra. There is no descent of the bladder, and you see a very good anorectal angle. So the symphysis pubis here in front, a very good urethra seen here, a very good vagina seen here, and an anorectal angle seen over here. So you see that at rest. You see that in contractions, you see that in coughing or exclaiming, you see that with just applying pressure, and you see it with Valsalva strain. And then you will get your answer very clearly. Now, there used to be this thing about the bladder being full, and that didn't work out so well. So this 300 ml bladder volume used to be a requisite, and we realized that most women cannot have that. And therefore, we now have settled for anything between 120 and 180 ml. And that's also equally reproducible. The funneling can still be seen, and prolapses can be better seen. And therefore, the 300 bladder is no longer required. Now, some people like to attach importance to actually studying the bladder neck. Here, this is done with a transabdominal view, and they try and look at everything with a transabdominal view and see the descent. Studies have always contained very few patients, and then all of them have mentioned that the bladder descent can be either 15 millimeters above or 48 millimeters below the symphysis pubis. So you tell me, does that make sense or not? It doesn't make sense. It absolutely doesn't make sense. So if the bladder neck does not come down to 15 millimeters above, and our patients are not the best at Valsalva, we do not anymore quantify bladder descent. The very fact that the bladder base, instead of being flat like this, comes down below and you get a tongue of bladder coming here at the back means that there is inappropriate bladder descent, and that is more than enough to explain some of the patient's symptoms. In the operating rooms, things are a little different, and there the urogynecologist might actually want to know the difference in the beta angle here, which the bladder base makes with the urethra, and then they say, okay, we need to know this angle first, and then they do the repair, and to tighten off that little tape, they then ask you to measure the beta angle again. This is something that is best seen in a workshop, and perhaps when Corona goes away, we'd be able to do that. But meanwhile, we just have to accept the fact that, yes, this is more an intraoperative thing rather than a routine thing. For those of you who wish to read a little more from the gynecologic surgeon point of view, there's an excellent book available by Mark Walters and Mickey Karam. And if you want to specialize in this, it's a very, very good idea. It takes you through all of the imaging, a bit of the clinical background, and also the expectations from imaging, and of course, where we use which surgical procedure and what imaging needs to be done then. The most common lesion that we see is a unilateral interruption of the Levator Ani complex. And in that situation, you find that this is the continuous one, this is the disrupted one, and the most common cause of this is truly a vaginal delivery. And you can see with your TUI, your multi-slice imaging, that this side is all nicely continuous on the left, and here, on the right and on the left, you find interruptions which are fairly large at one point. In fact, you almost have part of the vagina coming out through that defect, and that can be quite painful for some patients intermittently when the vagina gets stuck in that little defect. Now, you can have an avulsion on both sides, and you see here, this is the MRI picture, not very convincing. This is a 3D rendering, not very convincing. The real way to do this is to do a multi-slice image, arrange your lines so that you can see them. You can change the distance between these lines, and you can change the number of lines depending on the extent of the pelvic floor. And you can see here one avulsion this side, one avulsion this side, and a very straightforward situation. Now, here is another example to show you that that image that we showed you before was with a 3 megahertz transducer, the transabdominal one. But look what happens, the magic that happens when you actually see a vaginal transducer. The avulsion is much better outlined, it's rendered much more easily, and you can actually make out that almost all the fibers are disrupted here on this side, and on the left side, and some fibers are still okay on the right side. And note also that the moment you start doing this, you also start picking up very nice views of the various layers of the anal canal. There's been this myth many years ago that for urogynecology, you do need only a dedicated transducer and a dedicated machine with a front-firing transducer, not an end-firing transducer. But we do understand that by rotating our transducers now, especially our 3D transducers, you can get all the layers of the anal rectum, and therefore you do not need a dedicated unit. There used to be one manufacturer that was pushing this a lot. It's very useful if you're used to that technique, but if you grow up with another technique, you realize that you're getting all your answers with a general purpose machine. So in that case, why would you want to invest in a machine that would cost you between 10 and 45 lakhs just for urogynecology? It's okay for a very specialized center, but certainly not enough for a daily practice. Now, do remember what I pointed out was this business of a posterior interruption. You notice here that this is probably atrophy because there's very little muscle left here, just a little bit of muscle left here. And then from every angle we tried, there was nothing left here. And so you knew that this was bilateral posterior interruption because of atrophy. Then sometimes you find that all the landmarks disappear. You see them in 2D, you see a symphysis pubis, you're seeing a urethra, you're seeing a vagina, you're seeing the anorectum, but you don't see anything here. Well, this usually happens because of either severe atrophy, or it can be also sometimes when you have a prolapse. So then you start looking for a uterovaginal prolapse, and then you realize, oh my goodness, yes, I don't truly see a vagina here. I see some tissue. And so this then could be either an enterocele, or this could be a uterovaginal prolapse. So you have to keep your mind open when you don't have the landmarks and you start wondering. And then you say, okay, let the patient strain a little more, let that prolapse start coming down, or you make us sit or stand for about 10, 15 minutes, repeat the exercise, and then you get your answers. Remember also that if you find everything missing of the levator ani, that's more likely not traumatic, but it is again atrophy many years post-menopause. The prolapse can also be assessed by looking at where the vagina gets interrupted. And therefore, if you find that much of the front portion of the vagina gets interrupted or far in the lateral extremes or just unilateral, then you know that that is more likely to be due to a cystocele, which is a prolapse of the urinary bladder. And if you find that you are watching the 2D in live in a live situation, then of course you can actually see the bladder come into this area, and then you know, yes, this was the reason why I wasn't getting it in 3D. A similar thing can happen when you just don't see the vagina at all, and all you end up seeing is something here. And if you're watching it in 4D, then you realize, like I'm going to show you here, that suddenly when you watch it in 4D, part of the vagina is seen here. The rest of the vagina has disappeared here. But what I do see is bowel lumen coming all the way here. If it's bowel lumen, it can only be the anal canal, and there's no way the anal canal can come there, but because the anus is fixed. But you can get an enterocele, and therefore you then make a diagnosis of enterocele based on this morphology. Sometimes you can have everything. Remember that a rectocele is something that would bulge from the posterior aspect of the vagina. The enterocele would be in the middle, and that we don't have to panic about. Just one moment. I seem to have lost my connectivity here. We will just go back onto that. One moment. There we are. Are you still picking me up, or you're not seeing my screen now?
No, sir, we cannot see you. Yeah, now we can see, sir.
Can you see my screen now?
Yes, sir.
Yes, sir.
Let me just try and get back to my full screen. Just a moment. You see my full screen, is it? Because I seem to have lost my full screen, and let me just see if I can go picking this up. Can I just stop sharing and start this again, because I have lost. Yes, sorry about this. All right, and I will share my screen again. Yes, there we are.
Yeah, no, it's fine.
So there we were. This is where we were, and so we have This is where we were trying to say that, yes, depending on the rest of the morphology and whether it's at the back, you end up picking up a rectocele, and here you realize the entire vagina is obliterated. And then you say, okay, in real time, I could tell that this was actually the entire bowel coming at the back over here, and the bowel is moving in real time all the way in there. Now, the assessment sometimes you have to be very, very careful about, because with the enteroceles and the rectoceles, you can completely lose the vagina and lose your orientation. But the one thing that you will never lose is the well-defined muscular layer of the bowel at the back, in the anal canal. So therefore, if you look for this structure at the back and then you look beyond that, you can spot some muscle. You know that everything is lost here in terms of landmarks only because there is an enterocele and a rectocele, and that is causing this problem. Then you resort back to your 2D and say, oh yes, of course, we realize here that the bladder is coming a little bit, but not too much. But what's really coming in here is that the entire bowel is now gone, and the anorectal angle is related to a point much below the symphysis pubis, and that the anorectal angle I should have anticipated here at the level of the symphysis pubis or even higher. The moment you have an anorectal angle coming below the symphysis pubis, you know for sure that that is prolapse of the rectum. Can we pick up tapes? Yes, we can. Tapes come in different types. Some of them have brand names. Some of them have just standard names. The transvaginal tape, for instance, can be picked up, and you can see it all around the urethra, and you can see it depending on your contrast setting even better. And different tapes can sometimes be recognized, but you just have to become familiar with the tape that your obstetricians, gynecologists are using. But what you can make out is abnormal morphology of a tape. For instance, this tape is a tape that is too wide. It should have been just a loose circle. This is a tape that is too tight. This is a tape that has half broken. And this is a tape which has fractured. So beyond surgery, for recurrence of symptoms, again, the role of ultrasound to spot these. Remember that in this situation, you can not only see the tape by 3D and see that, yes, some of it is coming right into the urethra and causing problems. But if you become familiar with this foreign body kind of appearance that we often see in surgical complications, then you'll be able to see the entire tape all along in your mid-sagittal view, and you'll be able to see it in a coronal and an axial view as well. This is the position of the tape that you see here. You have to become more and more familiar with the type of brand of tape that is being used, and that would then give you an answer. So this is what I was mentioning about that anal sphincter thing, where we tend to believe that you cannot see the anal sphincter when you use equipment like this. All you have to do is to shift to the coronal plane, and you will be able to pick up the entire anal sphincter. You can then magnify that and get your answer, and see also that in the B plane here on your demonstration of the rendered as well as the acquired plane, along with that, when you see your B plane and the coronal plane, the B plane clearly gives you the entire extent of the muscular layers and the various layers of the anal canal. So you do not anymore need a dedicated unit to do this. You have excellent resolution, provided you get used to using a transvaginal high-frequency transducer, and you don't use our old-fashioned transabdominal transducer. So why ultrasound? Because it can be done? No, because it can be done if you know how to do it. It has now been proven to be better and easier to use than MRI, and because it improves patient outcomes. And thank you so much for your attention. There we are.
Sir, hello. Yeah, I think the first topic is over, sir.
Yes.
Yeah. Now we have the second topic, pelvic Doppler imaging.
Yes. And tell me, we'll take questions related to
after the.
so
we can take the questions after the second topic, sir. Once you.
Yes, that would be ideal. I will get my second PPT going, and bear with me for a second, and I will just open it, and then I will share my screen. So we're going to discuss color Doppler in gynecology, and we're so familiar with color Doppler when it comes to actual obstetrics, that we forget that yes, it has a role in this situation as well. Are you able to see my screen now?
Yes, sir.
Yeah,
It's the screen.
and my arrow is seen and you can hear me clearly, yes? So let's see what color Doppler in gynecology can do. And I'd like to let you know that, look, there are some very, very simple applications and there are some not so simple applications. So if we start with this, we have very simple to assess flow in a cystic space, whether it's an actual fluid loculation or not, as a landmark to confirm the ovary, to identify isoechoic lesions, to study cyclical changes, to assess ovarian torsion, and as a differential diagnosis of endometrial lesions, which we will discuss, tumor neovascularity, pelvic congestion, and we'll give you an overview of all of this, not to mention that we will lay a little bit of extra emphasis on cyclical changes and the role of color Doppler in infertility. So flow in a cystic space, very simple. You see a cystic space. You're doing a transvaginal scan. You know this is bowel. And you presume that this must be either a hydrosalpinx or an ovary. Don't take yourself for granted. Look at this situation here. You will see then that it fills up with color. And therefore, what's happening? What is happening is very simple, that we are looking at a situation where what is happening is that it fills up with color and therefore it's a blood vessel. It's not a cystic space. Beyond that, let me show you another example here, that it's not enough just to look at that. Sometimes on the basis of the flow in the pelvis, you can make out whether it's venous or it's arterial. But remember that venous flow in the pelvis can be pulsatile, so it's a good idea to see what kind of pulsations they are. If you have undulating pulsations like this with almost continuous flow, you know that this is a venous channel and not an arterial channel. The arterial channel will show you a nice straightforward arterial signal. So in a situation like this, we're trying to figure out whether this is venous or arterial. There's so much flow going in there, you're not sure. And then you realize that, yes, I'm picking up a lot more information. There is, of course, the iliac artery and vein here, the ovary sitting here, normal signals within the ovary. We know it's definitely the ovary because we have iliac artery and vein on the lateral aspect. We shouldn't see such varicosities on the medial aspect. But before I call them varicosities, I want to make sure they're not just dilated arteries. And so I switch on spectral Doppler and I pick up a nice, clean arterial signal. So I know then this is arterial congestion. And then the differential diagnosis becomes completely different. Differential diagnosis in terms of this is then associated not with the classical pelvic congestion syndrome, but the fact that this is either endometriosis, pelvic inflammatory disease, and so on. And that is why this has happened. So arterial congestion is always secondary to some disease process. Now, similarly, if you have spaces like this, you're not sure what they represent. And this was a patient post-abortal. We switched on color and immediately you realize that all these spaces were filling up. They were filling up with color, they were filling up with power Doppler, they were filling up with classical directional Doppler. And these are the three things that you can use to identify flow. We can use either conventional Doppler if you have higher velocities. You can have power Doppler in case your machine doesn't have directional Doppler. Most of us now like to use directional Doppler, and that's not expensive technology anymore. It's very useful when you're looking at anything that is congested, and therefore we now use directional Doppler. The simplest function that I always use color flow is to make sure that anything I see in the adnexa, whether it's truly ovarian or it's not ovarian. Because in this right adnexal mass, for instance, I wasn't sure whether it was an appendix or it was ovarian. I said, well, let me see. The appendix will always have a different relationship to the iliac artery and vein. And so this was obviously the ovary and a corpus luteum and not anything else. And therefore, and these vessels which are medial are usually the uterine and the tubal vessels. So this sandwich clearly tells me that, yes, indeed, I'm looking at a lesion which is within the ovary or a physiological change which is in the ovary. The other thing you use it for is when you're not getting very clear images in the transabdominal view, when you weren't sure on how much of this is vascular and how much of this is lymph nodes, then you just switch on color and you realize if it doesn't fill up with color and the vessels fill up with color, then this must be lymph nodes. And then you measure them and then you get your answers, yes, that whether these are pathological or not. Sometimes you find that lesions in the ovary are isoechoic, which means that the ovary looks a little more globular, looks a little bulky, but it looks completely normoechoic. What you do, you switch on color, and the first thing that you're likely to pick up in this is to realize that a lot of hemorrhagic lesions have the same echogenicity as the ovary, and the peripheral rim vascularity will then identify that this indeed is the corpus luteum of pregnancy, and the only way you can pick it up is by switching on color. So when you're looking at ovary that doesn't look right, or you're looking for something to explain the pain of a patient, then you say, okay, let me switch on color, and then I know that this is a corpus luteum with internal hemorrhage, and that must be the cause of the patient's pain. Classical torsion, again, is something that we find tricky to pick up because of peri-ovarian vascularity. We know that there are a lot of normal small vessels in the pelvis, and the smarter our machines become, the more we pick them up. We have here an ovary where we have some echogenicity in the center. We don't have a classical peripheral necklace of beads and so on. And yet we're picking up some vascularity here. And then I said, now, did this tort and detort? Is this partial torsion? The best thing is to resort to 3D in this particular situation. And then you say, okay, how does that happen? You suspect this lesion here on the basis of the rounding off. You realize that the vessel in it is also following a spiral pattern. You go on to then do a multi-slice, and you say, okay, of course, this is a corpus luteum, this is a hemorrhage, and it caused ovarian enlargement and the ovary twisted, and that's the classical appearance of the twisted pedicle. And very well seen. It can be seen, of course, on rendering, but even better confirmed on a multi-slice. Now, how do we go about these? The first thing to realize is that when we use Doppler, again, the higher the frequency, the better it is. So try and use a 6 to 12 megahertz transducer. It will give you much better Doppler signals. Remember that we have power Doppler, which is our old-fashioned one. We have direction power Doppler. We can combine 3D with power Doppler. And the other thing that we've now learned to pick up is slow flow. Slow flow is the latest piece of latest armor in our armamentarium. And we say, okay, here we go. A very, very slow flow of even less than 1 centimeter per second, or even millimeters per second, can be picked up with the help of slow flow. And you see the cystic area here, and you say, okay, if I see that cystic area here, then obviously this has peripheral flow. This can't be it can't be something which is it's not a pregnancy, because not near the endometrium, and the patient has no HCG. So is this an adenomyotic cyst, or is this a tubercular necrotic caseating granuloma? We know that caseating granulomas are avascular. This one is peripheral vascularity. This is an adenomyotic cyst. The rest of the uterus does not show adenomyosis. She had pain during her periods all the time. And then we did discover that what we thought was an old degenerated fibroid here was neither tuberculosis, but was definitely an adenomyotic cyst. It explained the disease process straight away. This advantage of not using color Doppler is very important, because we do understand that color Doppler depends on direction, mean velocity, range of velocities, and therefore works much better with actual high flow, and that doesn't happen in the pelvis, both in pathology as well as in physiological changes. Also, you have omnidirectional vessels, but therefore color Doppler does not work, but power Doppler works beautifully. This was our old-fashioned one that we used to use, then we shifted to directional power Doppler, and now, of course, like I said, we use slow flow. Now, remember also that with power Doppler, you can pick up a signal, and you can do the other thing that you can do is 3D power Doppler reconstructions. So just a visualization might answer some of the questions, but sometimes you need to answer questions further by actually showing the flow velocity waveform or doing a 3D reconstruction. And I will show you an odd example. Here, for instance, is a mass in the adnexa, and this was a mass which was actually an ovary that had metastasized, and therefore all she was doing was to take a vessel reduction treatment, and Avastin, as we call it, and then we wanted to compare whether it was responding. So we did a 3D vocal, including color and grayscale, and then we followed her up after treatment, and we looked to see whether the indices of vascularization index, flow index, and the VFI had actually gone down. And if they had gone down, then you know you had it before and after, and that tells us that she's responding to the anti-angiogenic measures. Now, what do these indices stand for? The VI relates to the number of vessels. The flow index relates to the total amount of flow in the VFI, which is the vascularization flow index, tells you about both. So it's ideal to actually use all three, and they show up anyway. There are no norms for this. It's always a before and after comparison, except in infertility, which I will discuss with you very shortly. Do remember that when you use powered Doppler, if you use random settings and increase the color gain or reduce the PRF, you can make anything look very, very dramatic. Same patient, same day, and you can see not so much drama, a little bit of a polyp here, and over here, lots and lots of peripheral vascularity and lots more vascularity in the lesion. This is just because we put the PRF very, very much lower, and this will increase the gain. Every equipment has its own setting, and you must become familiar with it. Your apps person must set it for you correctly, and then you come up with this. And the settings that I use are a PRF of 0.6, a power of 4.0, a color gain 38.4, wall motion filter set at either 75 or 60. And then, of course, the persistence and the reject automatically get set when you do that. And then you get your answers. But if you were not to use this, you'd not be able to apply any of the stuff that's going on. The most common use that we have for this is to show cyclical endometrial changes in infertility. And you switch on color and you try and see whether you have subendometrial flow or flow into the outer layer of the endometrium, flow into the mid zone of the endometrium, flow into the inner zone of the endometrium, or whether you have flow into the cavity. And this is how we rate a good endometrium. So not just triple layer, but much more than that. And this is naturally cavity flow, which is the best kind. All you do is transvaginal scan, switch on powered Doppler, set it at the right setting, which I have now made into a preset, and you get your answer. Remember that you can combine 3D powered Doppler also with volume calculations with 3D, and you do your basic thing. You draw around the volume of interest by using a touch screen, and then it tells you the VI, the FI. It also tells you the total volume by using a grayscale method. And then you can see whether the total amount of endometrium is enough, and you can also see whether vascularization is enough. How do we use this information? We know that in the endometrium, you have these peaks, and this is something we published many years ago. And we showed that there was a peak here just before extrusion and a peak here at the time that was the actual time, 3 days, to an absolute low that we see here, 5 days post ovulation. And this was what told us that, yes, that's the window of implantation. Now, if you have a VI that's less than 1.0, a flow index that's less than 31, or a VFI that's less than 0.25, on the day that the follicle reaches a size of 18 and the clinician is planning an injection of HCG or LH, then that's the time to measure it. And if these values are like this, then there's no implantation. In that case, you can then not transfer in that particular cycle. Now, do remember that there was another factor called subendometrial vascularization, which got very popular in the late 90s. But the absence of subendometrial flow does not preclude a pregnancy, and therefore we've dropped subendometrial vascularization from our standard reporting. Uterine artery Doppler, in the conventional way, you go laterally, you trace the uterine artery till it passes through the infundibulopelvic ligament, gives off the descending branch, and then starts going up. It appears as a curve. You insonate that. And if the PI is more than 3.019, then the chance on the day of the HCG administration, the chance of implantation is almost zero. So it's a very, very useful thing for endometrial receptivity. Remember that there have been some elegant studies with myometrial vascularity, and the myometrium is more vascular during the menstrual phase, and therefore you will not try and assess myometrial vascularity during the menstrual phase. There's also an increase in myometrial vascularity in the mid-cycle, and therefore then again you don't like to say that, oh, this is a hyperemic myometrium. That's physiologic hyperemia. We presented this many, many years ago. It's something that was completely thrown out of the window at that time by the international community, and now this article has been cited 82 times in the last 3 years. So it's quite a shock that something gets recognized almost 12 years after the technique actually came along. The other thing that we use in infertility is perifollicular vascularization, tell about quality of follicles. And we do find that we have to look at the degree of vascularization of the periphery. Grade 1 is less than 10%. You can see here, very minimal vascularization, and some of these are less than 10%. Grade 2 is about 10% to about 1/4 the periphery. And then you finally have a nice all-around one like this one, which is a greater than 50%. And that's how we divide the grades. Remember that just prior to extrusion, you find an avascular rim in the follicle. So particularly if you see free fluid in the cavity, in the pelvic cavity, then you don't say, okay, this is not a vascular follicle. You just say it got overstretched. Some people used to do a perifollicular peak systolic velocity, but because of angle corrections, we no longer use it. We used to say that good follicles have a peak systolic velocity more than 10 centimeters per second, but that really does not apply anymore because we could never, in a flat image, work that out correctly. And therefore, we don't really use that anymore. When you find good follicles, you always have a better oocyte retrieval rate. You have an increased number of mature oocytes, increased fertilization rates, and decreased triploidy rates. And therefore, it might be wiser to do this routinely when you're monitoring folliculars evaluation. Now, the other thing that is a common problem is a thin endometrium. Now, an endometrium can be thin if follicle is not good, but if my follicle is good and it shows this wonderful vascularization on the periphery, then I must find a good endometrium. So if I find this combination, thin endometrium, vascularized follicle, then I must start thinking of either a tubercular endometritis, a previously treated endometritis, repeated curettage, a clomiphene citrate cycle, prolonged exposure to oral contraceptive pills, or an abnormal immune state of vasculitis such as an SLE and so on. And therefore, you get an answer. But to start talking about a thin endometrium in the absence of a good follicle is completely illogical. Now, remember that the gynecologist has lots and lots of options. So it might be very, very good to mention these and then they know what to do with it. But it's nice for you to become familiar with the options because sometimes you can use the combined wisdom of all the clinicians in your town and let them know that, look, this is how things work and this is how we can do it for you. And then you give them these options and they say, oh yes, of course, I heard this in that conference. Thank you for guiding me. I'm going to try and use this. What about other uses? Well, sometimes polyps are pretty obvious. They're echogenic. Some some polyps are hypoechoic. Those are usually the adenomyomatous ones, and they show a nice bump, like a fluid level. Some of them are poorly defined. But what I wanted to show you was that you can actually tell the histopathology based on what it is. So if you find a polyp, and it has this complete bizarre vascularity, and particularly this business of it dividing into two, dichotomous branching as we call it, then you can start suspecting very strongly a malignancy, because dichotomous branching or irregular bunch of vessels like this at the periphery of a polyp are not signs of a benign polyp. Those polyps need to be handled very, very carefully, and also that the pathologist has to be very careful to look for focal disease. And then here, 3 different cases. Lesion partly in the cavity, partly outside, poorly defined, heteroechoic. Lesion partly in the cavity, partly outside, poorly defined, heteroechoic. And here a smaller lesion, partly in the cavity, partly outside, poorly defined, heteroechoic. They're all 3 different. How do you tell them? We switch on power Doppler, and you find here that in this lesion, the first one, there's peripheral flow with the vessel becoming narrower, better seen on 3D. Typical peripheral vascularity of a fibroid polyp or a submucous fibroid. Adenomyomatous polyp, the second one, you found that there is this spoke wheel vascularity in the center, and therefore then this becomes an adenomyomatous polyp. Very important to remove this, particularly in the infertile patient, because this is likely to prevent implantation. And the third one is what saves the gynecologist's life, because that is neither a polyp nor an adenomyomatous polyp nor a fibroid polyp. It is actually an arteriovenous malformation. and you can demonstrate it and suspect it even on a standard power Doppler and show actually which vessel is going in and out with the help of 3D. And then your gynecologist will say, thank you so much for saving my patient's life. I didn't do this as an office procedure. I will try all the alternatives. Start with OCPs, maybe switch on to uterine artery embolization or a superembolization for this. And then I will talk in terms of doing anything. This is a lifesaver to prevent exsanguinating hemorrhage in the hysteroscopy suite, for instance. What about malignancy? The moment you find bizarre vessels, and we will discuss these, you start suspecting that something is wrong. So a blob of vascularity, dichotomous branching, start thinking in terms of a poorly defined lesion within the endometrium as being malignant unless proven otherwise. Do remember that when you see a polyp or you have been told that there's a polyp in the vagina coming out, the only way you can identify it is by switching on power Doppler over the cervix. And if you don't do that, then you'll never be able to identify that the polyp is actually there. So whenever you are looking for a cause of abnormal bleeding, always take a box and put it on the cervix and on the rest of the uterus to make sure that you're not missing an isoechoic lesion, which is actually vascular. Isoechoic means that the lesion itself looks identical to the surrounding uterine or cervical tissue. So here we have nothing that looks like a pedicle, and here you see that there is a pedicle, and this was the edge of this polyp was actually prolapsing outside at the internal os. Now, fibroids, we don't routinely use vascularity, but if you don't have bizarre and intense vascularity, then you're comfortable that it's not a fibrosarcoma. And you know that there's a lot of nonsense going on in the social media about morcellation of fibroids at laparoscopy. Luckily, things like this say, oh, look, if you don't have too much vascularity, it's unlikely that this is going to be a disease process. There are a lot of descriptions on what fibroids show, but none of that is consistent, and I never use it in my clinical practice. Adenomyosis. Yes, when we see a cystic space, I've already described this to you, then you wait till the actual period is over, and then you start looking at a cystic space. You want to differentiate between a caseating granuloma, a degenerating fibroid, and an adenomyotic cyst. And if it has a lot of vascularity, you know for sure that you're looking at an adenomyotic cyst. Like I said, the actual tuberculosis lesions have a lot of endarteritis, so they don't have vessels in them, and that's how you can identify them. Some miscellaneous uses before we close. I have about 5 minutes. Length of residual cavity, vascularity of the septum, and endometrial volume are to be used for surgical decision-making for patients who are being considered for a septoplasty or a septal resection. We know, of course, that very often pregnancies will carry on, and therefore we say we don't have to operate every septum. What do? You look at the length of the septum and compare to the length of the residual cavity. You look at endometrial volume in the mid-cycle. But on the other hand, if you switch on vascularity and you do this at the right time, which means that if I'm assessing it in the mid-cycle, I know it's going to be vascular. If I'm assessing it during menstruation, it'll be vascular. But if I measure this in the middle of the first half of the cycle and I find a vascularity, then I know that this is likely to become a symptomatic septum, because this area of the hypervascularity forms a pacemaker, and that makes peristalsis start in the septum, go down through the fundus all the way down, and the entire conceptus gets milked out of the uterus. Therefore, we must assess every single septum around day 10 of a 28-day cycle and assess to see whether it's vascular or not, and that might help in decision-making. For looking at the volume and residual cavity, of course, it might be better to see it on day 13, 14, or 15 of a 28-day cycle. Ovarian hyperstimulation, well, we have some well-defined 2D criteria, but in pelvic Doppler, if you have a stromal PI less than 0.75, then you know that, yes, there are greater chances of hyperstimulation. So you do this during a cycle, depending on when you see too many follicles. Can we assess stromal volume in any other way? Yes, we assess stromal volume by 3D measurements, but importantly, the functional aspect of a, of a hypertrophied stroma excuse me, in your patient is a very good way of looking for downregulation in IVF patients and in the effect of OCPs in your non-infertility patients that have polycystic ovaries, because hyperemia is related to androgenic activity. So you do a vocal along with power Doppler, and then you downregulate the patient or give her OCPs, and then you repeat the power Doppler 3D, and you compare the VI, FI, and VFI and see how much it's fallen, apart from actually looking subjectively on the 2D on how much power Doppler signals you have there. And if they disappear, you know you're well downregulated, and then you know you're on the right track. Can we use it for some other things? Yes. A lot of adenomyomas on the surface of the uterus and a lot of endometriomas will show telangiectatic vessels, and directional power Doppler can help you identify these. So the gynecologist can be ready for a greater amount of oozing type of bleeding rather than anything else during the laparoscopic procedure. To finish, I want to mention neovascularization, which is something that you need to identify. And we identify it using 2D and we identify it using 3D, and I'll show you how we interpret these images. One, of course, is this very simple thing that you have a classic dermoid. You want to see, yes, does it have a pedicle or not? You try and identify and you say, okay, no pedicle, but definitely dermoid, end of story. What do you do in congestion? If it's an endometriosis, you will identify arterial congestion and you say, okay, likely to be benign because malignant tumors don't have arterial congestion. But the true difference is not in identifying just 2D features. We know what the 2D features are, but in looking at 3D features in patients who are in doubt, because when we were trying to use spectral Doppler in the 90s to identify benign versus malignant ovarian lesions, we realized that although we started using a cutoff RI of 0.4 or 0.3, the sensitivity and specificity were very, very poor. What we didn't understand was that we shouldn't look at the pattern of flow, but at the morphology of vessels. And what does this look like? You forget about the spectrum completely. You forget about 2D because that only gives you vessels in cross-section, and you need to look at it from a 3D point of view. And the vascular morphology is very classical in malignant ovarian lesions because tumor vessels lack muscle coats, so they are variably dilated. They have arteriovenous and venovenous anastomoses, which you can spot with power Doppler. They have vascular lakes that you can see with power Doppler, and they have disordered branching, which I will show you. And therefore, you end up with dilated, tortuous, and saccular vessels. You have phases of the vessel that are very elongated and other phases which are coiled. And you could have them both in the same vessel. Dichotomous branching, both for ovarian and endometrial lesions. And then, in a normal vessel, you're actually supposed to get the vessel giving off one side branch and then becoming narrower and giving off another side branch. And this is lost in malignant lesions. And let's look at some examples. For instance, here, looks like a terrible lesion, looks very bizarre. But the moment we do a 3D reconstruction, we find very nice leash of vessels inside this lesion, on the periphery of the lesion, and some of the vessels going inside. This is a typical endometrioma, which is either infected or something where the vessels have started growing into old clot. And this is a typical bird's nest picture. But if you look at each one of the vessels, they become narrower and narrower. The vessel gives off one side vessel and then becomes narrower. And then you see each of these vessels here at the edge, also wider vessel and then narrow vessel. And therefore, then you know this is a benign lesion. Now, here we have a solid area with vascularization. I'm not sure whether we're looking at hemorrhage, but you have vascularity in a lesion, you know it's likely to be malignant. And then you look at vessels, completely bizarre vessels, some narrow, some thick. As a vessel goes from outside to inside, it should become narrower. And here you have such a big, thick vessel in the center. You can be absolutely sure that this is not an abscess or an endometrioma. This is a malignant ovarian lesion on the basis of vascular morphology. Another lesion here again, I thought initially on 2D that this was a vascular lesion and that this was a hematoma. And then I switched on power Doppler. There was vascularity inside it. Hematomas cannot have vascularity inside it. And look at the peculiar type of vessels we picked up on a 3D reconstruction. We knew immediately that this was malignant. This is one of my oldest cases. It goes back to 1999. And thin-walled, relatively flaccid. And we just started doing 3D power Doppler at that time. And then I realized that, oh my God, this is a very thick vascular wall. And what we saw otherwise in the lesion without color was a thin wall, but the wall was actually this thick, and that was all veno-venous anastomosis in the wall. Therefore, in this 28-year-old, where we never had even thought that it could be something like this because all she had was abnormal uterine bleeding, we realized we were looking at a possibly malignant cystadenoma. And then we said, oh my God, we have to be careful about this. Sure enough, we did, in those days, we weren't too comfortable looking at malignant lesions laparoscopically. She had an open surgery, and the histopathology was a well-differentiated cystadenocarcinoma. And then the family went on to have all of those done. Tortuosity by itself, you have to be careful about, because some vessels in the pelvis do become tortuous. So even if you have a tortuous vessel, like in this particular benign fibroma, notice that it becomes narrower as it goes beyond, and it only gives off one side vessel. So sometimes tortuosity you don't have to take seriously. The other things, but the vessel becoming narrower and one side vessel is a great sign for a benign lesion, and that's exactly what this turned out to be. What about this? I thought again hemorrhage, vessel which becomes bulbous, and we confirmed that there were more vessels where we did a multi-slice evaluation, and this turned out to be a malignant fibroma in a completely asymptomatic patient in a normal sized ovary. So we just now look at every ovary with the switch on of power Doppler. There's no question of doing any ultrasound without that. The same thing applies for any mass, really, because when we give the aorta a simple rule score, the moment you pick up a no blood flow, then you have a color score 1, then that becomes a benign lesion. On the other hand, if you pick up a color score of 4, which is lots and lots of vascularity, as you see here, then it reconfirms that the bizarre 2D appearance coincides with the bizarre vascular appearance, and we're looking at a malignant lesion. So it supports an aorta scoring for benign versus malignant. So how do I end? I end by reminding you that color Doppler studies now form a relevant part of every pelvic evaluation and, of course, every infertility cycle, because in the infertility group, improved implantation take-home baby rates actually improve with this. And thank you so much for your attention. There we are.
Yeah. So it was a very good session, and a very complex session, I would say. The first topic was really complex, but yes, I think we need to start doing first at least some 50 normal cases of transvaginal or transperineal 3D imaging.
5 cases, my dear, is all you need to do.
So I think we have a little bit of low IQ than you.
Is it so only 5 cases?
We really need
5 cases is what you need for normal anatomy, and then you're just set for it. You don't need it. This is
yes, sir, definitely needs a lot of practice.
Yes.
So I'll just announce one change. Actually, since we are already late, and it is going to be too tiring for the next topic to happen. So the next topic on twin by Chander sir is going to take place maybe next month. So we have a good 20 minutes for question answer round now, that we can disturb you more.
My apologies to Chander for doing this to her.
Yeah, because it's actually already 9:35, and
it is. My apologies. Yes.
When we take questions, is going to be more than, I think, 9:50 or so. So I think the next topic is not possible today, sir.
Sure enough. Yes.
So Tushar, please go ahead with the questions first. Tushar, can you hear me?
Yes. As usual, it was an excellent presentation by Khurana sir.
Thank you.
Master in making such a complex and difficult topic a simpler one. And thank you, sir, for giving a valuable time and educating us about this topic. I will ask some audience questions are there. So I will ask the question first.
Simpler and interesting.
Yes, sir. First question is from Dr. Dipti Sawant.
Yes.
Sir, are there any USG guidelines for pelvic floor imaging?
There are none so far. You and me have to make them.
Okay, sir.
Yes.
So one more question by the next person is that can we do this transvaginal, this 3D pelvic imaging by linear probe? Because you have mentioned about the abdominal 3D probe and the TVS 3D probe.
Yes.
Can we do this with a linear 3D probe, if available, the transperineal imaging by this technique?
Yeah, but
Will it help?
you won't be able to do a 3D with a linear
Yeah,
probe.
you need a
Exactly.
volume probe.
Yeah, the
Exactly.
linear volume probes are very large probes
Yes.
and very tricky to use. And then you get very stuck with it. And then you remove that probe, and then to actually cover a linear volume probe, the linear volume probe is a big square. There are no covers for it, and those covers are so expensive. The companies charge you 450 rupees for a cover, and that really kills the costing of the study.
Okay, sir. So one more question by Dr. Meghna.
Yeah.
What exactly we need to see in stress incontinence patient on B mode?
Yeah. So in B mode, the first thing, of course, we do is to exclude other pelvic pathology and KUB pathology. And then you ask the patient to first cough, and then the urethra will open and you can actually demonstrate the leakage of urine at that time. So that's a straightforward thing called stress urinary incontinence or genuine stress incontinence as a sign. Then you want to look for associated bladder descent or resistocele. So you ask her to do it in Valsalva, and then you will see that the bladder, in case it is associated abnormality, it will go down very much. But the main thing is to demonstrate that funneling and incontinence as a diagnosis when she coughs or she strains.
Okay, sir. Sudhir sir, so any questions?
Sir, can something about pelvic congestion syndrome, sir?
Yeah, so I'd shown a few slides. Pelvic congestion can be of two types. It can be genuine pelvic congestion, which is a venous congestion. And so whenever you see vessels or you see any cystic space in the adnexa, you switch on color. Then you switch on spectral Doppler. The arterial signal will tell you it's either endometriosis or pelvic inflammation. Venous will tell you that it's genuine pelvic congestion.
We will be able to demonstrate reflex in Valsalva maneuver, sir.
Oh, yes. So what happens is that once you've demonstrated the venous congestion, you want to know whether it's something that does show a reflux. Unlike in the varicocele in the male, the pelvic venous congestion does not correlate, the reflux in those vessels does not correlate with symptoms. So we don't routinely do it. It may be present or absent, and Valsalva will show the vessels really rising, but it doesn't correlate with symptoms.
It has no clinical significance.
It has no clinical significance.
Sir, as childbirth causes significant alteration of pelvic organ support and levator function, is there any role of pelvic floor ultrasound which help us to identify the women at high risk of operative delivery or significant pelvic floor damage?
I want this question repeated again step by step. I think there are two questions in one question, no? Can you repeat the question again?
Sir,
Can you repeat the question?
Yes, sir. Sir, as the delivery or childbirth causes significant alteration of pelvic organ support, can pelvic floor ultrasound will help us identify the women at high risk of operative delivery with significant pelvic floor damage?
No, there is no such thing. The pelvic floor damage is completely unpredictable because we have no idea how much the fetal head is going to rotate. So it does not tell us on which patient is at risk for pelvic floor damage.
Okay, sir.
Yeah.
Okay, sir, one more question. So tell me, which indication do you think is most commonly you have picked up in this imaging, pelvic floor imaging? What is the condition? It is very easy to pick up and it is going to be very useful. All the clinicians can definitely rely on this technique, and it is easy for us also to learn. So what is that 1 or 2 indications you think we should try doing this technique?
So one of them is stress incontinence.
Okay.
The easiest thing to pick up and the most frequent. The
Okay.
second thing is pelvic organ prolapse,
Okay.
which is very, very easy to pick up.
Okay.
And the third thing is the presence of fibroids.
Presence of
Fibroids.
Okay, sir.
Yeah.
Okay. So one more thing is how to differentiate, a fibro. I know it's a very simple question, but yes, many times we have difficulty in differentiating fibroid from adenosis, focal adenomyoma.
Yeah. So
with
there are 3
color
different
Doppler.
lesions. Yeah, there are 3 different lesions: a fibroid, an adenomyosis, and a focal adenomyosis. A fibroid, focal adenomyosis, and an adenomyoma.
Yeah.
So in a fibroid, you will find peripheral flow. The flow in a fibroid is always peripheral unless there's degeneration. Then you might find odd signals in the center. The adenomyoma will always have a spoke wheel appearance, which means vessels originating from the center of the lesion and going out. That is an adenomyoma. And the focal adenomyosis shows vessels traversing, normal uterine vessels traversing the lesion. Then that becomes a focal adenomyosis.
Thank you. So that is a very good differentiating point, actually.
Absolutely, yes, and very important for the surgeon as well.
Yeah. Yes, sir.
Yeah.
And sir, Tushar or Sudhir sir, any questions? Any questions?
I
Sir,
see. Yeah.
is there in your series you have a multi-organ prolapse?
Oh, very frequent.
Chronic constipation patients and
there are many patients actually who have a uterovaginal prolapse with a cystocele and a rectocele. That's a very common presentation. And then you have enteroceles as well, and there can be combinations of these. And it's very rare in the Indian population because we're so protein deprived to have just a uterovaginal prolapse. They often almost always have a cystocele along with it.
Yeah.
I see one question in the chat box on the percentage of perifollicular vascularity and whether the machine calculates that. No, it's purely subjective.
Okay.
That you see the periphery and you say whether it's 0 to 10, 10 to 25, or more than 50.
So a role of Doppler in PID. One question from the viewer.
Yes, there is absolutely no role of Doppler in pelvic inflammation in its classical sense. Yes, if you have pelvic pain, you might use it to exclude a torsion. But this business of trying to oblige the gynecologist by saying, I found something, or you feel that a patient is not getting good value and you say there is hyperemia. No, it makes no sense. The only thing is that, yes, you find an echogenic lesion which is intensely vascular. You see it's an abscess in the ovary or an infected endometrioma. But for generalized, everyday pelvic inflammatory disease, there is absolutely no role of pelvic Doppler.
Sir, is there any cutoff value for normal bladder neck descent?
Yes, we discussed that briefly. Bladder neck descent can be anything from 15 millimeters above the symphysis pubis to about 4 centimeters below. So we don't actually quantify bladder neck descent anymore. We just go subjectively.
Thank you, sir.
So role of Doppler in pelvic adhesions.
Yeah, absolutely none.
Okay. None. Okay, sir.
None. It's a 2D diagnosis, and you slide and glide, and you know that the adhesion's there. Okay. And of course, if they're intrauterine adhesions, the synechia, you and me like to call them, then those are easily seen on 2D and 3D, but no role of Doppler.
So one more question. When we do a pelvic Doppler for infertility before embryo transfer, actually there's one more thing which has come up is the presence of the endometrium peristalsis.
Correct.
So they say if there is peristalsis, it's not a good time to implant, even if all the other parameters are normal.
Sure enough.
So is that
true?
Two
things to peristalsis. Okay. One, on the day of HCG administration, you will notice that there are at least 2 waves per minute, which start at the cervix and go all the way up to the tubal end. that indicates good endometrial receptivity. Then at the time of embryo transfer, if you find that that you actually have peristalsis, then we don't transfer at that time. Then what you do at that, you use piroxicam. So piroxicam is a wonderful drug to reduce endometrial peristalsis, and within an hour, the uterus becomes silent and you can do your embryo transfer. Peristalsis is a 20-year-old concept.
Okay. Sir, actually one of the viewers have asked to repeat the answer for focal adenomyosis versus adenomyoma versus fibroid.
Terrific.
This again on demand, actually.
No problem. So the fibroids have generally peripheral flow on the outer margin of the lesion. And only if there's degeneration, you might find some odd vascular signals in the center of the lesion. The adenomyoma has very little peripheral flow, and you will usually find a spoke wheel pattern of vascularity in the center of the lesion. The focal adenomyosis will find normal uterine vessels traversing through the lesion.
So is there any exception to this rule, or it's always like that?
It's almost always like that.
Okay. So one more question: how to differentiate AVM from post-abortal enhanced myometal vascularity?
How wonderful. We have a new classification on that, as you know, but the fact remains that the two cannot be differentiated because they are actually the same. So there is no difference. So you can have angiomas that open up, you can have hemangiomas that open up, and you can have arteriovenous anastomoses that open up after the procedure or without a procedure. And they can open up with medicinal termination of pregnancy or surgical termination of pregnancy. So you cannot tell them. The only way is when you get worried, is this part of gestational trophoblastic disease? Then the only support you have is of HCG. Otherwise, you can't tell the difference between these lesions at all.
So there is one more question from the viewer.
Yeah.
When do we take uterine artery PI? When in the cycle? When in the cycle? And do we take average of bilateral arteries?
How sensible. I'm so glad you asked this. Well, the uterine artery is always done on the same day as you have a leading follicle, which is more than 18 millimeters, which is the day you want to give your HCG or LH trigger. We do not do it on other days because that's the day you assess it. Then you always do it in the same place, which means as soon as the artery has given off the descending branch. Do we use a PI? No, we don't use the PI. We always use the better vessel when it comes to infertility.
So do we take average of bilateral arteries or individual?
No, you do not. You just take whichever is the better PI, which means whichever is the lower PI is taken as the correct PI. You don't take an average like we do for preeclampsia.
Okay. Okay, sir. I think I've answered all the questions which have been mentioned.
Yes.
In the chat box. Waiting for some more questions to come, if at all, since we have 5 more minutes, and then Mindray people can take in.
There's a very nice question here.
Yeah.
And Meghna wants to know whether we should be telling the gynecologist when they should give HCG injection or they should decide on their own. The 2-3 important rules in clinical medicine. One is that when you're right, you should let everybody know that you're right. Maybe you won't discuss it with the patient, but you definitely discuss it with the gynecologist. Also in IVF cycles, they have to be very careful. You don't want all the follicles to extrude. So you might actually then decide that, look, we must try and time them a little better. And in down-regulated cycles again. So the optimal time is, truly speaking, should be ultrasound guided because that's really the best indicator for endometrial receptivity. The problem arises that a lot of people work in batches and they want a particular thing to coincide. Then obviously we have no role to play because that becomes mechanical. But ideally speaking, you and me should be guiding them that like today is the best day to get the best oocyte. And that is given with the help of that whole rule of endometrial receptivity, which of course is a talk by itself. Yeah.
Tushar, anything you want to ask, sir? Sudhir, sir? Any more questions?
Yeah, good.
Anything?
Sir has covered almost all everything.
because there are so many things in pelvic imaging, not only pelvic floor, but overall pelvic imaging.
Yeah.
How to, sir, there's one more thing. When we see an ectopic pregnancy,
Yeah.
Many times what happens is you scan a patient and you have a thick endometrium.
Yeah.
You don't see anything, outside, or you don't see any particular sac kind of a thing.
Mm-hmm.
But you see a corpus luteal cyst actually, which looks little bit confusing if it is in the, but you see a sac outside the uterus, very close to the ovary, and it also has a spoke. It has a ring of fire appearance, and you have a cyst inside.
Correct.
So that, how to differentiate basically a corpus luteal cyst from an ectopic pregnancy?
Yeah,
If you
so
don't see
one of
anything
course
inside.
is the location. The corpus luteum is always inside the ovary.
Ovary, yeah, that is true.
And occasionally, very, 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 very rarely, you can have an ovarian ectopic. But how many do we see in a lifetime? One or two or three? The other thing is that you must understand that the vast majority of ectopic pregnancies are located in the femoral end of the tube. The femoral end of the tube will be seen as a vascular ring of fire infero-medial to the ovary, because that is the relationship of the femoral end of the tube to the ovary. We tend to think of a scarecrow appearance, and we think that the tubes are like this on the ovary. No, the tubes are like this on the ovary. So this is the uterine end of the tube, and this is the femoral end, and the ovary is in between. So this femoral end will show that mass, which is infero-medial to the ovary. The second most common location is in the main part of the tube, and that will always be seen typically supero-medial to the ovary. And therefore, these are the two usual appearances that tell you, okay, ring of fire, be careful of that area.
Okay, sir.
And then, of course, tenderness. Probe tenderness is a great way to confirm that, yes, that lesion is trouble.
Okay, sir. Any other? There are a few more questions which have popped up again, sir.
Yeah. Very
Does
good question.
Does PSV have a value for diagnosing AVM?
Yeah, 2 or 3 nice, beautiful papers in the good old days, all thrown out of the window.
When do we take zone 3 vascularity?
Okay, so when you have vascularity up to the inner zone, but not looking at vascular signals within the cavity, then that's called zone 3 vascularity.
So how to know it is a resolving ectopic after methotrexate?
That's right. Very, very good question. Once we've given parenteral methotrexate, the patient can often get cramps and you get worried, and you might see a bit of free fluid and you get worried. The correct way to assess this is by assessing vascularity between the ectopic mass. So what we do is that irrespective of any ectopic mass and what the clinician is going to choose, for every ectopic pregnancy we pick up, we actually do a 3D vascular Doppler and calculate the volume of the mass, the VI, the FI, and the VFI. And then whenever the patient has symptoms and we redo the ultrasound, we know that the first thing that happens when a pregnancy is resolving is that the HCG level goes up, because the apoptosis of the cells gets released into the mother's vascularity. So the HCG is going up, the patient has cramps, the doctor then says, no, I need to operate. That's not true. What you have to do is to look at that ectopic mass and repeat the vocal 3D plus power Doppler, redo the VI, the FI, and the VFI, and if those are going down, you know that mass is resolving. So it's the most sensible way of ever following up a pregnancy, ectopic pregnancy.
Wonderful. Sir, one more. Is it safe to curettage a patient who has taken abortal pills, now presents with spotting, thickened endometrium, and hypervascularity? How do we counsel?
Yeah. So if there is a diffuse hyperemia, of course you can do that. There's no problem. If you have a focal vascular lesion, it is best left alone and correlated with HCG levels. So if the HCG levels are not too bad, then you know that, okay, I can destroy that endometrium and that pregnant decidua with methotrexate, so I'd rather use that. But at all points, you must avoid a curettage, because the patient will bleed to death.
So what basically, how do we differentiate AVM versus written RPOC?
The most intelligent way of doing it is by correlating it with HCG levels.
Okay, so not by imaging.
Much as we have this paper and that paper and 23 papers from Turkey and 25 papers from Persia, we just don't follow any of that. It's an HCG correlation, inhomogeneity on the ultrasound as the only sign, vascular or non-vascular, and in HCG level, which is increasing.
Because if we go in case of AVM, I think it's going to be a massive bleed.
It's always a massive bleed. Yes.
So the best way of doing it is by doing HCG levels.
Absolutely.
How do we do it every alternate days when we just follow it up, or sir, what is exactly the?
No, it's nice to do them at least 48 hours apart.
Okay.
And the clinical recommendation is 72 hours apart.
Okay.
But what happens is that the weekends in between, where everybody's on holiday. So in that case, if it's close to a weekend, then you do it after 48 hours. If it's not close to a weekend, you do it after 72 hours.
Correct. Wonderful, sir. I think so many questions which are very, very common, but very important though, have been answered very beautifully by you, as always. And I think there are no more. Yeah, there's one more question again.
Last question on deep infiltrating.
Last. This one last. It's the last question. Now I think we are out of time also.
Yeah.
What's the role of Doppler in DIE?
That's deep infiltrating endometriosis.
Okay.
And there is no role of Doppler in deep infiltrating endometriosis.
Thank you, sir. Thank you. Thank you very much, sir. I think it was a very, very good session.
Wonderful session.
Everything was really good, as always, with Khurana, sir. Now, I would like to thank all the viewers, the organizers, and my colleagues who have given time for this webinar to happen. And definitely, I'm really sorry that we could not have the second session by Chander sir because of lack of time. And this topic has taken us so much brain, so much of energy. This topic has taken us that we actually don't have.
Apologies for overshooting.
Yes, full two topics, sir.
Yeah, exactly. So I think Bishwaroop, now you can take over.
Yeah. So thank you, Dr. Ashok Khurana, for this wonderful session, sir. We learned a lot from you. So I would like to give the session to Mr. Xavier to give the thank you note. Over to you, Xavier.
Yeah. Thank you, sir. On behalf of Mindray India, I would like to thank Harshad sir, Sudhir sir, and Sir sir, and also entire Chhattisgarh Radiology Academy team to giving us for an opportunity to get associated with you. And also special thanks to Dr. Khurana sir for having a deep understanding, for giving us a deep understanding on pelvic floor package. And also we would like to, in future, we would like to associate with more such events, better in online. In during pandemic, we would like to do online as well in Chhattisgarh, in Raipur. We would like to do offline events as well. So thanks a lot. Yeah, thanks a lot, and take care. All the best.
Thank you. Thank you very much.
Thank you. Thank you, everyone.
Thank you all.
Bye-bye.
Thank you.
Good night.
Good night.
Thank you, sir.
Good
Good
night.
night.
Good night.